All right, so just a reminder of a few meeting logistics. This call is being recorded. All of our participants at this time are on mute, but we, definitely want to hear from you. Please use the chat box at the bottom right hand of your corner, of your screen, sorry, and feel free to add any comments, ask any questions, and we will be monitoring the chat box throughout our presentation today. And also, the meeting materials will be posted on the ESRD National Coordinating Center website within the next 5 to 7 days. So, who is on the call today? We have many of our dialysis facilities and transplant professionals. We have our End Stage Renal Disease Network staff. We have CMS on the call, so Centers for Medicare and Medicaid Services, our leadership team, as well as some patients and families. So lots of folks are joining a call today. And as Stephen mentioned earlier, we love to have interaction in our calls and we want to hear from you. So please feel free to drop comments and questions in the chat box throughout. So our key objectives for today, we want to provide an overview of quality improvement strategies to help reduce hospitalizations. We want to identify primary and secondary drivers from the hospitalization change package to reduce admissions and emergency room visits. And last, we want to identify strategies to empower our patients to collaborate with their healthcare team in reducing avoidable hospital admissions and emergency room visits. So these are our key objectives that we're going to focus on today, and you're going to hear a lot of great innovative ideas as we proceed in our presentation. So what is a LAN call? LAN is Learning in Action Network, and it's a forum to bring people together around a shared idea, around shared opportunities and challenges, and it presents an opportunity to offer as well as request information and share experiences to improve identified topics of discussion. And in the case of our call today, our topic of discussion is focused on reducing hospitalizations. So the way that we spread best practices on a Learning in Action Network call is by listening and sharing your approaches and also sharing your experiences. And we want you to do that in our chat box. We want to identify how shared information can be used in your facility. We want you to think about at least one idea that you can take away from today's LAN call and utilize in your facility. And last, we want you to commit to sharing your learnings with other colleagues. We have these Learning in Action Network calls every month, and so you will be getting more information throughout each month about different topics. So when you receive an invite, be sure to spread that information with other colleagues on your team and invite them to the calls as well. Questions to run on. So questions to run on, again, are just ideas or questions to kind of keep in mind as we progress through our topic today. And so a couple things to think about. What aha concepts will you hear on today's call that you can possibly introduce to your organization's leadership team? How might your organization incorporate ideas from the hospitalization change package to reduce your admission rate in your facility? And how might my organization adapt new approaches in empowering our patients to reduce avoidable ER visits and hospital admissions? So our first poll question, and I would like again for you to drop your answer in the chat. Are you familiar with the End Stage Renal Disease National Coordinating Center Hospitalization Change Package? So if you ever used it before, are you familiar with it? Have you ever heard of it? Just give me a yes or a no in the chat box. All right, so I'm seeing a couple of responses. I'm seeing some no's. All right, I'm seeing a couple of yes responses. Very good. Okay, for those that are not familiar with the change package, you're on the right call at the right time because we are going to talk about it, give you a little bit more information, share with you where it's located on our website, and you're going to hear some great examples of how to incorporate some of those changes into your practice in your facility. So the ESRD change packages, here's a great example of several of those change packages. And what a change package is a collection of innovative ideas that high-performing facilities have tried and tested in their facility and have received great outcomes. And so the different change packages are focused on a lot of the metrics and objective and key results, or KPIs, that you're utilizing in your facility. So some of those ideas focuses on home dialysis, patient experience of care, health equity, kidney transplantation, vaccination. We're also working on a new change package for depression and also dialysis care in the nursing home. And on today's call, we're going to focus on some of those change ideas in our hospitalization change package. All right, just to give you a little bit more detail, when you access the change package, the way you kind of read and use this resource is that you're looking at primary drivers and secondary drivers. And so primary drivers are those bold aims that we want to create a practice around. And secondary drivers are those actionable change ideas, are those interventions that you can implement that's going to help you accomplish your bold aim. So for example, primary driver number 2 is surrounding implementing continuous quality improvement. And secondary driver A and B, again, are actionable items, or actionable interventions that you can utilize in your facility in order to implement a quality or continuous improvement process in your facility. So more to come on how to utilize this hospitalization change package. And with that being said, I'd like to introduce our first speaker in First Network. So we'll have 2 presenters and 2 networks presented on our call today. And our first is from ESRD Network 3, is Annabelle Perez. Annabelle is the Quality Improvement Director for Network 3. Network 3 covers New Jersey, Puerto Rico, and the U.S. Virgin Islands. Annabelle has been with Network 3 for 10 years and leads the reducing hospitalization, increasing home dialysis, and improving the care of the dialysis patients residing in the nursing home. So she's involved in those 3 initiatives. So welcome to the call, Annabelle.
Sorry, I had to take myself off mute. Thank you very much, Gayla. I'm happy to present Tracy Santora of Liberty Hamilton in New Jersey. Tracy began her career in dialysis as a patient care technician in 1994, just as I did, and became a registered nurse in 2001. She has been at the clinic since it opened in 2010 and has been the clinic manager since 2011. Tracy enjoys traveling and spending time with family and friends, and she attributes her facility success to having a great team. Liberty Hamilton has 17 stations plus 1 isolation station. Their patient census includes patients receiving in-center and peritoneal dialysis. I'd like to thank Tracy for accepting our invitation to share her work and her success with decreasing hospital admissions and readmissions. Take it away, Tracy.
Good afternoon, everybody. I'm going to discuss reducing hospitalizations by utilizing the PDSA cycle, Plan, Do, Study, Act. Our objective was to decrease hospitalization by 4% within the 90 days. Our plan to carry out the cycle was to improve team communication and involvement, create a culture that contributes to low hospitalization rates, by the interdisciplinary team through daily huddles, staff meetings, and lunch and learn in services. The plan for data collection was to track, trend, and analyze the data, track hospitalization and related measures. Next slide. The to-do list to carry out the plan was to educate staff on the action plan in place and goal for the clinic, identify RNs responsible to complete the post-hospitalization checklist, complete daily huddles with staff to inform them of any patient admissions or discharges for that day, identify any patient issues, concerns that could lead to hospitalizations, obtain discharge summaries within 24 hours, implement action steps, and monitor. This included weekly rounding with a nephrologist while visualizing our fluid management dashboard, monthly nephrologist rounds with the entire interdisciplinary team, which included the clinic manager, the charge nurse, the nephrologist, social worker, and registered dietitian to discuss patient-centered care and address all patient concerns and issues identified. Next slide. So the change package elements we utilized from the ESRD National Coordinating Center included to create a culture that contributes to low hospitalization rates, and we emphasized on teamwork, being approachable, listen to ideas from the staff, review key elements such as estimated dry weight, be approachable, and have open communication when speaking with the staff and patients. Establish channels of communication to facilitate information, foster open communication, complete those daily huddles, and make sure that you had a liaison for communication between the hospital and the clinic, and we utilized our administrative assistant. We always wanted to track hospitalization and related measures and monitor mistreatments. We tried to provide the patients with knowledge so they can plan an active role in staying out of the hospital. So during our monthly education, we concentrated on causes for that previous month's hospitalization, such as mistreatments, fluid volume overload, etc. Next slide. We wanted to create a post-hospitalization culture. So we wanted to keep focus on patient-centeredness by showing empathy to patients, treating them with kindness, trying to be welcoming by smiling, be approachable, and engage the support for the patient through family, friends, and discuss the short-term and long-term goals with the patient post-hospitalization. We tried to provide a culture that contributes to low hospitalization rates by share the facility's vision and outcomes with the staff, ask how the current process and plan is going, how we can accomplish it together, and work together as a team to involve every single team member. We want to keep communication that facilitates information sharing, such as open communication between management and staff, create an environment where the staff members are approachable regardless of the position, and that happens with your daily huddles and your weekly rounds. Next slide. So we try to implement a continuous quality improvement. So we track, trend, analyze hospitalization. We reviewed the hospitalization trending workbook and hospitalization discharge summary. Over the past 12 months, we identified root causes of admission, and we focused on the top 3 diagnoses. For our clinic, that was wounds, cardiac arrhythmias, and congestive heart failure. So what we did was we engaged the nephrologist, myself, the charge nurse, RNs, PCTs, the social worker, the dietitian, and administrative assistant in review of the data and development of interventions. We completed post-hospitalization checklist. We continued weekly rounding with the focus on the estimated dry weight, their blood pressure, and any lab draws, and follow-up appointments per the discharge summary. We reviewed admission and discharge with the patients, and we gave out red flag education. Next slide. continually follow up on the hospitalization. We documented, tracked, trended the hospitalization, any ER visits, and mistreatments. We put into a root cause analysis tool to identify any driving admission diagnoses. At each treatment, while the RN is assessing the patient, we always ask, have you been hospitalized since last treatment? We perform daily monitoring of absences and hospitalizations. We complete our post-hospitalization checklist and scan into our doc manager. We incorporated the social worker to monitor mistreatments with the reason and address any psychosocial and transportation issues. Our culture here that we've developed was to have 0 mistreatments. Next slide. We wanted to educate patients and staff, so we asked some key questions. Do you know why you were in the hospital? We provided education post-hospitalization for causes of the hospitalization to take an active role in staying healthy and how to stay out of the hospital. We continually followed up with appointments. We completed medication reconciliation with the patient within the next 2 treatments. We use printed materials that are easy to read and in the patient's primary language, and we utilize the language line if needed. We completed to do weekly rounds to discuss the labs, the blood pressure, and the estimated dry weight. Next slide. So our study was reducing hospitalization. So our baseline rate between June of 2020 and April 30th of 2021 was at 3.198%. Our current rate is 0.325, and that was from 5/1 of 22 to 3/31 of 23. Next slide. So the PDA cycle continued, and to act, myself, the charge nurse, to continue to educate any new staff on the clinic processes that are currently in place. We wanted to decrease the number of hospitalizations and continue. And if the initial PDSA cycle was not successful, we would reevaluate and repeat the PDS cycle for another 90 days. Next slide. How to sustain, the steps to sustain improvement. We continued the daily huddles, weekly rounds. We continued to complete the post-hospitalization checklist. We continue to provide educations to patients post-hospitalization. We continue to foster open communication for staff and patients, and we continue to track, trend, and analyze hospitalizations. Next slide. The post-hospitalization checklist. First treatment post-hospitalization. We obtain the hospital name and the reason for admission. We notify the nephrologist of the patient's return and discuss the plan for post-hospitalization evaluation. We draw a hemoglobin or any missed labs since their last treatment. We confirm with the physician if any IV antibiotics are needed. We evaluate the access and document in the patient's medical chart any infection, complication, or procedures that were performed while hospitalized. We evaluate fluid management. We complete the fluid assessment. We review the estimated dry weight, and we reach out to the nephrologist for any new order if it's applicable. We review with the patient the reason for their hospitalization. We verify all follow-up appointments that are needed, and we document always a clinical note in our electronic medical record. Next slide. So for our post-hospitalization checklist for the second treatment, we want to make sure that we evaluate their albumin and nutritional status. We evaluate the hemoglobin that was drawn, resume ESA per MD order, or update the ESA order as necessary. We obtain a discharge summary. We confirm if the patient had any transfusions. We obtain any cultures that were drawn within 24 hours of the hospital admission. We complete a medication reconciliation and update the medication list. We update the medical record with all diagnosis codes, whether it be chronic or acute, and then we close out the absence and the hospitalization record. Next slide.
Thank you, Tracy. I have a few questions. So in the last year, we've heard often from facilities that staff turnover is a major barrier. And I would like you to share how you managed to sustain these processes that, that are very comprehensive and thorough, um, such as the team rounding, the post-hospitalization checklist. How were you able to sustain those when going through some staff shortage or staff turnover?
When we have staff turnover, staff shortages, we sort of like huddle up in the morning to delegate the task and each person's role for that day. And I feel that helps with like the patient continuity so that the patients don't feel like we're understaffed as well, um, in that process. So we try to make sure like delegation, like say, we had a nurse call out in a PCT, we would just delegate those tasks and make sure that they're completed. And then we sort of follow up at the end of the day too to discuss, like I said, if anybody had any concerns, and we always follow up with each other after each shift in regards to people leaving, above their dry weight, and we notify the nephrologist. And then we also try to have them rescheduled for like an extra treatment. And we do really try to obtain like a zero mistreatment culture. So we have like almost like a we know like the chain of command. So if the patient calls in and they get the administrative assistant, she's very good in saying, "Hold on, I'm going to go get you the nurse." The nurse then goes and educates the patient on why it's so important. She notifies the charge nurse, who usually speaks with the patient as well as myself, and we try to reschedule them for a different shift or at a sister clinic.
Excellent. Thank you very much. Um, Could you share a little more about that red flag packet that you mentioned you provide to your patients? Like, how do you decide what goes in that red flag packet, and how does the staff review that with the patient?
So the patient, based upon their diagnosis, is like, say, if it's surgical, and they had surgery, we try to our Fresenius has a great education on our website. So we pull from those red flag packets, the education, and then when we're sitting with the patient in regards to like that follow-up. Do you know why you were hospitalized? Do you know what follow-up appointments are needed? Do you need help in making those appointments? We get a lot of feedback from the patient, and at that time, that's when we also will educate them.
Okay.
And that's trying to have them like buy into like staying out of the hospital and that continuity of shared information. Like, what is the barrier? Like, say, sometimes it's fluid volume overload and they didn't realize like sodium. So we'll then involve like the dietitian. It's a collaborative approach.
Okay. Thank you. And you mentioned that you asked the patients, why you were in the hospital. So what did you find, when you asked those questions? Are patients well aware of why they were in the hospital? Are you, re-educating them or following up with them on the reasons why they were in the hospital?
I think I would say it would be a 50-50. Times patients were very informed of why they were in the hospital, what follow-up appointments were needed, what medications were adjusted. Other patients had no idea of the admitting diagnosis. Like we've had some that say, well, I had pneumonia, but the hospital diagnosis was actually like congestive heart failure, fluid volume overload. So they needed education on why it wasn't pneumonia, what came out with the diagnosis, and then we sort of, give them those red flag education, and we sort of close the loop with follow-up as well. So when we're doing those rounds with the physician, we ask, are there any questions? We sort of keep a calendar of like post-hospitalization follow-up, say with a cardiologist or like a pulmonologist. And we sort of, when we're weekly rounding, we revisit, did you go for your follow-up visit? So I feel that has engaged the patients too, to understand that we're here to help them and that we actually care and we're following up with, their post-care as well as them.
Okay. And that's my last question. How did the patients respond? So you've made a lot of changes and you've incorporated other resources. How are patients responding? Are they more likely to attend those post-hospitalization appointments? Are they more engaged in, adherent, in their care? What are you seeing on your end as a
I think the
result?
patients are very engaged now, like in post-hospitalization or even follow-up, because patients that have been hospitalized will now come in and say, "Hey, I just wanted to let you guys know that I have an appointment with cardiology for my yearly follow-up." They come in, and I think because of like our medication reviewed monthly, as well as especially post-hospitalization with them, physically bringing in all their bottles like we do, but they're much more engaged. So they understand the importance, and they'll come in now, like if they go to their primary care physician. And that's the other thing. We tried to make sure that each patient had a primary care physician, because we found, when we first started the process, a lot of patients were utilizing their nephrologist as their primary care. When everyone seen in the hospital did wind up with, a primary care physician to visit, we tried to encourage them to follow up with them because each physician has a specialty.
Yeah. Thank you, Tracy. Thank you. I'll pass it to Gayla.
Thank you, Tracy, and thank you, Annabelle. Tracy, we actually have one more question from our CMS SME, Stephen Preston. He's asking, would you please provide a little bit more information on your process for identifying the root causes for the top 3 medical reasons that you listed or that you stated for hospitalization?
How did we?
Your process for identifying the root cause.
So on the Fresenius website, we have great RCA tools that I utilized. So you put the numbers, like, you get your hospital discharge diagnosis. You put those diagnoses into a pre-populated, not a graft, but it prints out the graft of your top 3 hospitalizations. So you would put in, like, say, CHF, wounds, vascular access infection. It will populate like the percentage of your patients, what they're being hospitalized for. So
Gotcha.
it's a root cause tool that I utilize from Fresenius's website.
Okay, and then based on those, what comes out as your root cause analysis is where you implement specific interventions in order to improve the outcome.
Correct.
Gotcha. Very good, very good. Stephen, any other questions for you before we look to the next speaker?
Go ahead.
Okay, awesome. Thank you. Thank you, Tracy, and thank you, Annabelle.
Thank you.
All right, so our next speaker today is with ESRD Network 15. We have Amy Carper. Amy is a social worker for the past 22 years. She spent time working in various healthcare settings, including long-term care, hospice, and case management and transitions of care, as well as in the dialysis units. She's been with the ESRD networks for the past 10 years and been with Health Services as advisory group for the past 8 years. She's been working on, most recently, the reducing hospitalization focus for the past year. So, Amy, thank you so much and welcome to the call.
Thank you so much, Gayla. So, many of you are familiar. I kind of pop in and out of different networks, but have consistently been with and continue to work with Network 15. Today, as you can imagine, my speaker is more calm, and she is at a clinic where some of the feedback is interfering with her audio. So she has joined additionally on I'm looking. She's additionally joined us on the phone, and so Gayla, if we can work a little bit to get her unmuted, that would be super. She is at a clinic where we knew the bandwidth wasn't great enough to get her on camera this morning, but now again, she was listening to the presentation just before. That was super, and had some problems with it cutting in and out.
Oh, okay, so she's on the line.
Oh,
I'm here. I couldn't get on the line, so I'm on with the computer for right now.
Okay.
Okay, very good.
Well, we'll just
Okay.
continue to roll and adapt and roll and adapt, just like you do in the clinic. So Moore is also joining us in between a couple presentations that she's doing for their QAPI meeting. So she'll hang with us for as long as she can with questions. But Moore comes to us today from DaVita Dialysis, where she shares at more than one clinic, with 16 years of experience as a social worker, both doing in-center dialysis and home. And with her in-center experience, has some patients who do nocturnal dialysis. She is a social worker that believes in being really proactive with home and transplant initiatives and any other initiatives that assist patients in living their best life. Today, she'll be discussing the work done at the clinic where she's at regarding her reduction of hospitalizations. In utilizing the data from the network and really focusing on those CMS or Medicare primary individuals. We have identified that at her clinic, most of the patients, even though the rate was a little bit high, had only been to the hospital one time each. So today she'll be sharing with us about a patient who had been to the hospital more than once and how she and the staff at the clinic had been working together to really try to identify keeping that patient and all others out of the hospital for if possible. So Moore, I will turn it over to you, and thank you so much.
All right. Well, thank you so much, Amy, for allowing me to share kind of what our clinic's experience has been using the hospitalization initiative. If you go to the next slide, please. Perfect. So we began with the initiative and we had 24 Medicare patients of our 31 patient census that were included in this initiative. And when we took a look at hospitalizations, we found that only one of our 24 Medicare patients had been hospitalized more than once during the timeline. And so he was admitted to the hospital once in October of 2022 and then again at the beginning of 2023. Next slide. The patient we identified was a 56-year-old male. He started on dialysis back in 2018. The first hospitalization that he had, he was in for 8 days for sepsis. The second one was just for 1 day due to anemia. Next slide. There we go. So our interdisciplinary team took a deeper dive in reviewing these particular hospitalizations for our patient, and using the hospital change package that was provided by the network, we really kind of honed in on the primary driver number 4, which was, education being the best approach to working with our patient. We knew that his hospitalization was for sepsis that had been related to a pneumonia, which was ultimately related to fluid overload. We thought that maybe there had been some missed opportunities that we could educate the patient. So this is where we decided we would start tackling the issues. According to the hospitalization change package, we'd work to provide the patient with knowledge so that he could play an active role in staying out of the hospital. We educated him on the key issues and the consequences that can result with hospitalizations and mistreatments and such, fluid overload, pneumonia, all that. We'd educated, just as opportunities presented themselves, and we definitely made sure to include the family in this education process as well. As far as we found out that in our clinic, our staff communicates with patients very differently. And when having these hospitalization discussions, it appeared that our nurses and dietitians, when speaking with the patients, came across to our patients a little bit more authoritative, felt as though, patients felt as though, they're being held accountable So some patients, just in general over the, past have seemed more guarded, self-conscious, and I think in turn become a little bit defensive, thinking that, they're blamed for their hospitalization. Not that this is ever the intention of our staff, to make patients feel as such, but naturally, I think patients just kind of associate those roles as more rule following, rule abiding type conversations. And so when the conversation took place with the social worker, it tended to be a little bit more relaxed. It seemed that patients overall feel a little bit less judged, more comfortable, and through that comfort, they're able to be a little bit more honest and share the struggles they're really having leading up to those hospitalizations. Next slide. So our clinic used this tool, which was provided by the network, with our hospitalized patients, and this patient in particular. But instead of using this tool as, a question answer form to fill out, we found it much more effective using this as a guideline and simply having a conversation with our patient. So we would review this, take a look at it ahead of time, and then proceed to have that.
Amy, did we lose more? I think you're on mute, Amy.
Can you guys hear me?
She's
Can you hear me?
back. Yeah.
We
I'm
can
back.
hear you now, yes.
Where'd I lose you guys at?
You were talking about this being more of a conversation. So you review the tool, and then staff kind of go out and use the ideas for it.
Okay. Yeah, so I was just saying that my favorite part was just really kind of learning and finding out, how comfortable the patient felt being back home after their hospitalization, if they felt that their medical condition had been treated long enough in the hospital to return home in a stable condition. Next slide. So we also provided this resource to our patients. This was also created by the network. We use this as a reminder for that patient and any of our hospitalized patients in hopes that this would help facilitate and increase communication between patients and staff. So for example, if our patient stopped a particular antibiotic or started a new medication, this would visually prompt them to communicate with the dialysis team. Same thing if there was an urgent care visit overnight or on the weekend on a non-dialysis day. This would be a way to kind of help remind patients and their family to let our facility know so that we could catch anything early on and hopefully avoid hospitalization. Next slide. So this was a network checklist, and like this network checklist, DaVita has its own internal checklist that incorporates a lot of the same things listed here. And we use this checklist to help remind our staff, to review the electronic medical record, look at the hospital discharge instructions, assisting patients in making follow-up doctor appointments. We're making timely medication changes in the system. So everything is, reflective of, their hospitalization and then moving forward. All of this done with the intentions of best supporting our patients post-hospitalization. Next slide. So our team meets monthly, as I'm sure most dialysis clinics do, to go over hospitalizations, but we also still meet on a weekly basis, and using a really similar format to this, our interdisciplinary team is looking for trends. We're looking at missed opportunities for keeping someone out of the hospital and seeing what we can do to help, hopefully avoid any future hospitalizations. Next slide. And so in our review of this particular patient, the 56-year-old gentleman, you know, we noticed that there were definitely things that we were able to do. And so some of the changes that we made is we began asking patients about, you know, their coughs. We reviewed fluid. We looked at dry weights of our patients. And through this, we, you know, doing all of this stuff, we also, in addition, provided them with education that was provided both by the network and DaVita Resources. We continued working as a team to address these struggles, using, you know, the social worker, the dietitian, the nurse, and even our technicians who are sometimes the front lines and get pieces of information that we don't have. And so when we really worked as a whole team, we were able to just do some solid work with these patients, using some motivational discussions with our patients about reducing fluid intake, you know, really trying to search for what's motivating the patient to make the change, rather than just asking a patient to cut back on their fluid consumption, really just finding what that motivating factor was. And then finally, we continued to have conversation with the patient's family, educating them about the importance of fluid restrictions, as well as reporting any medical symptoms and changes earlier. And that is it.
So More, I really appreciate your time today. The questions that I've seen come in the chat are mostly about resources. I'm going to ask you now, do you need to scoot back to your meeting, or do you have just a moment for questions?
I
And it's
actually
okay
need
either
to
way.
run back. I need to run back into my meeting, but hopefully you can help them with the resource questions and where they can find all of that stuff. But
Perfect.
I
Okay.
appreciate you guys. Thanks so much.
Thank you for sharing your experience today with working with this initiative.
All right. Bye-bye.
Bye. So Gayla, I I'm sorry that Moore wasn't able to hang on with us. She was wiggling us in, like I said, in between a couple reports she needed to give at the quality meeting at her facility. And you know, we're all trying to get patients in there too. So I think she wanted to just be sure she was able to be everywhere at once. It looks like one of the questions is if the reducing hospitalizations is written in an appropriate grade level. And I'm not sure if that's for the change package. The change package is really for staff to be using to educate themselves about how to change sort of the energy in their facility. So so if that's regarding the change package, that that absolutely is written at a very simple level on identifying problems and some options in moving forward to solve them. Um, the checklist is available absolutely on the Network 15 website, which is available also on the HSAG website. I think we try to cross share amongst networks, but I will certainly forward that checklist to you, Gayla, so that you can share it out with the minutes and the slide deck that go out today. So
Absolutely sound great. Thank you,
yeah,
Amy.
yeah. I don't know if anyone has any other questions, or if Stephen does. We can certainly try to muddle through what we can without more.
Any particular questions from you, Stephen? All right, he may have stepped away. But I will also.
I'm
Sorry,
here.
there you are.
I just sent a message that two excellent presentations, really good. I'm glad we could get more for a few minutes away from our meeting. We know these people are busy, so good stuff. So.
Gotcha. Very good. Look like we do have one question for hospital representatives or maybe our speakers. The increased hospitalization in my facilities is associated with patients being discharged so early from the hospital. Patients are still feeling sick, so they end up going back into the hospital. How can hospital managers prevent this from happening? And patients need to be discharged when they are stable enough. So Any words of pearls of wisdom there, Tracy or Annabelle, or with those initiatives that's happening in your geography, Amy?
Gila, I will say I am working with a collaborative actually out of Network 7 that does a circle back to give feedback to hospitals about the different discharges. And it was designed to use in nursing facilities, but we're adapting and adopting it, or adopting and adapting it for the different dialysis centers. So you can really give hospitals trends of what you've seen in patients coming. So a lot of times what we know is patients are seen to be really stable, and they've had breakfast and they look great. And then after a 15-hour day of waiting to get discharged in a 2-hour ride home, and they're home and they just want to go to bed and they haven't had dinner or their medications, they wake up early to go to dialysis the next day and sometimes don't even have their pain medicine filled from the hospital. So it's just different things like that. That again, if people could be discharged earlier in the day, or if people need prescriptions waiting for them, or just what can we identify from each hospital system to really support people in success. Again, they might be physically stable enough to no longer qualify to be in the hospital, but we don't want them falling apart as soon as they get to the car door. So that's something that we're implementing, is a circle back form where, again, they can give some aggregated information to the hospital about the discharges that they've received and how those have gone. Also, if they've gone really well. So thank you for, giving patients prescriptions on their way out the door, or whatever is going well, so that those processes can be not only replicated but shared with others.
Awesome. Thank you, Amy. Annabelle?
This is Annabelle. I'll just add that unfortunately, dialysis facilities are not able to control when patients are discharged from the hospital. And I think that's why that post-hospitalization process is so important, that facilities are really engaging with patients the day they return from the hospital, and that, like Tracy presented, that they are keeping close tabs on anything, related to that hospitalization, and that the patient is aware of the next steps, of the things that they need to do following that hospitalization to keep them out of the hospital. So I think that, the role of the facility with engaging the patient soon after that hospitalization is key to keeping them out of the hospital.
Awesome.
This is Steve Preston. Barbara brings up the good point. Medicare beneficiaries can challenge it. There is the BFCC contractor who basically patients need and folks need to work through. They basically cover Medicare beneficiaries for hospitalizations. So we might want to see if the NCC could identify, because there's two different contractors who cover different parts of the state. If the NCC could get that information and provide it out to the networks, then they could share it with folks, because it really needs to be worked at the individual hospital level on what's happening, because CMS doesn't want patients getting discharged too early either, because it's not good for, the patients, and it certainly is going to cost us more money if people are getting readmitted because they're getting discharged too early. So, but it needs to be worked through for the BFCC contractor.
Gotcha. Thank you. Thank you for that feedback, Stephen. And we'll definitely follow up on that for sure.
So this is Amy, and I just want to toss that out there real quick. Again, one of those questions on that questions about you form that Moore talked about is, do you feel like you are stable at home? Do you feel like you have what you need, or do you feel like you got discharged too soon? Because even if you leave the hospital, if you're not feeling stable, what we know is people become very quickly self-fulfilling prophecies. So if you think you're going home, chances are you're going home. And if you think you're too weak to stay there safely, whether you need to make a little pit stop at a sniff or for some rehab, or whether, again, maybe your treatment plan wasn't stable enough for you to really stay there. We need to tweak it now that you're home, or we need to do whatever we need to so that you feel safe. Because again, we are sometimes creating what we fear. So if I think I'm going back to the hospital, chances are you'll see me there.
Amy, you're very correct, and that's also why I think it's important that the message get to the hospital discharge planners for Medicare beneficiaries. I mean, this isn't applicable to everybody, but certainly Medicare beneficiaries should be utilizing the home health nurse assessment, because one of the first things they do is they make an assessment of the environment, because it's possible we're discharging patients to a home environment that basically won't help that stability, and they can basically do the assessments and provide some additional support to help keep the patients out of going back to the hospital, since that's what that Medicare benefit is really all about.
Awesome, great feedback, great comments, and great dialogue, everyone. And we'll certainly follow up on the request and get that information back out. See a comment from Mary. So discharge planners also need to ensure patient transportation. Patient transportation needs to be reset up post-discharge for their dialysis treatment. Very true, very true. Thank you for sharing that, Mary. All right. Any last minute comments before we move to our next slide?
Ela, I see real quick, someone's asking about the resource on challenging the discharge. And since that's through the BFCC QIO, I can, I'm sure that it's on their website, but I also want to be sure that if there's a special link or anything, working in some different arenas, in addition to dialysis in my lifetime, I know what that information really looks like. Sometimes hospitals have it specifically, but Medicare really does have information on contesting a discharge. They have to give you usually 72 hours if you're leaving a sniff, and if you're leaving the hospital, there is an amount of time that they need to give you, so they're not just swooping in and saying, gosh, pack your suitcase, pack your toothbrush, and you're out of here. So so again, it's not something that the networks probably have, but I'll make sure that if I can support you in finding that or identifying it, I'd be happy to.
And Amy, you're very correct in everything you state. I think the most critical aspect is that there are two different contractors that cover different parts of the state, and it's not like we've divided it down the middle of the country or anything, so you really need to know which particular contractor you need to go to so that you're dealing with the right folks. But yes, the information is there, and there is a full explanation of processes for discharge and how they can basically work with Medicare patients to help challenge, and hopefully that would spread not only from Medicare but any other patient as well, because hospitals should have formal processes so they aren't discharging patients too early.
Awesome. So Amy and Stephen, can I work with you too, or one or the other, to kind of get some of those resources so we can get them out to the larger group?
I'm happy to, Gayla.
I think Amy Carp has the contact information for the BFCC website. She should be able to provide that.
Absolutely, and with a map, so everybody can sort of identify where they sit and who to call. So I'll share that with you, Gayla, and you can get it out.
Perfect. Thank you. All right. And I see one other question or reference to resources. So I just dropped two links in the chat box. One is for professional resources for the change packages, but on that link, there's also a tab for patient resources. And those patient resources can absolutely be utilized as you need it, regardless of what organization that you belong to. So their resources are there for your use. So please feel free to utilize it as you need to. All right, our second polling question really quickly. Now that you've heard this presentation, what is the likelihood that you will use some of the ideas from the hospitalization change package? So feel free to drop your responses in the chat there. We hope that you've certainly learned some golden nuggets that you can utilize in your facility based on some of the questions. I see there's lots of interest for some of the checklists and different ways you can utilize some of those best practices in your facility. So we definitely hope that you were able to gain some great ideas and that you'll be able to implement a lot of those ideas in your facility to work towards decreasing those hospitalization rates in your area as well. All right, I see some very likelies and I see some yeses. We'll utilize the help in our clinic. Very good. So really happy to see that this presentation was super helpful to so many of you. All right, so moving from learning to action. As we talked about at the beginning of our call, a Learning in Action Network call is about learning new things and pivoting and putting those new learnings into action. So moving from learning to action, we want to be able to share best practices from this presentation with your colleagues. So this presentation is being recorded. It will be posted to our ESRD NCC.org site. You have the link in the chat. So you're able to share it with your colleagues and continue to use some of those best practices. We want to consider using the hospitalization change package as a supplementary resource to improve your patient outcomes and overall patient care experience. And also, as we've learned on the call today, a lot of great ideas to empower your patients to be active participants in avoiding those hospitalization admissions and emergency room visits. Just a little reminder, we do have another Learning in Action Network call on next Thursday. It's going to focus on home dialysis. So if you have not received a registration flyer, please reach out to your network and they can supply one for you, or you can also email us here at the National Coordinating Center and I'm more than happy to send you a flyer as well. In addition, again, as I mentioned earlier, we have these Learning in Action Network calls every month. And so we definitely have several that's coming up in the month of June. We will be focusing on COVID-19 and vaccination. We also will be focusing on depression. And in the month of July, we're going to be focusing on health equity and transplantation. So be on the lookout for a lot of the registration flyers that should be coming to your email inbox. Last but certainly not least, we are listed on social media. So Facebook and Twitter, YouTube, and again, our website, ESRDNCC.org. So please reach out and see what's happening here at the National Coordinating Center. And thank you everyone for your attendance on the call today. I would like to thank our presenters with giving such great topics, as well as Network 3 and Network 15, representatives from our other 18 networks, as well as our CMS colleagues. So thank each of you for joining the call today, and this is the end of our call, and have a great rest of your day. Thank you.